So good afternoon. My name is Mike Peterson. I'm the manager of the toxicology department for ACM Medical Lab. If you have not seen him before, John Battaglia in the orange shirt at the wall over there is your sales representative. He's here to help and make sure you get stuff ordered properly and any concerns with supplies and billing sort of stuff. I'm the guy that you talk to if you have questions about interpreting test results or figuring out what to order and what sorts of things you should expect to see. Jennifer emailed John to ask if we could come out and have a discussion of some things, some concerns that have been discussed around the practice. So the things that I got were some questions about things like what sorts of specific drugs are tested as part of the drug panel that you're ordering. And we have a handout to go around here that describes what each test actually is designed to detect.
Send a couple around now. They're laminated, so you don't worry about them. Plus, I have some extras I'll leave behind. So.
That's what you get.
Well, you don't get any.
One. No, well, you guys
So this is exactly the sort of thing that you can scan and make available on your shared drives or through email to people so they know exactly what it is they're looking for. What sorts of illicit drugs and controlled medications require separate tests to be ordered? There are some big ones. So let me walk through some of the places where there are some things that are common misapprehensions about drug tests. So you want to test for amphetamines. The amphetamines tests that we perform look specifically for amphetamine and methamphetamine. If you have a patient who is taking methylphenidate, they will not return a positive result. So if you have a patient who says, I'm taking Ritalin or Concerta, and that's the reason why my amphetamine screen is positive, that is not a valid answer. It's exactly the same as if you have a patient who's taking a methylphenidate type drug and you don't see a positive amphetamine screen, you're not supposed to see one. There's a specific there's a specific test for methylphenidate because while methylphenidate acts like an amphetamine, it doesn't respond to the amphetamine test. And so it's not possible to see that as a testing outcome. It's just not present. It doesn't respond to that particular compound.
What about Adderall?
Adderall and Vyvanse are both amphetamine-containing drugs, and so you ought to see those. In amphetamine, when we look at results for patients that have methamphetamine present, it's possible to see a methamphetamine positive where there's no amphetamine present in the sample. Now, biologically, you shouldn't see that happen. Your body demethylates methamphetamine into amphetamine. And so there are some sources of methamphetamine that don't do that. So if you look at Vicks nasal spray, it contains a form of methamphetamine that is not bioactive. It works as an antihistamine, but it doesn't have the psychoactive effects that street-type methamphetamine or digoxin, which is a prescription type of methamphetamine. And so there are cases where we see a sample with a positive methamphetamine and no amphetamine. Our protocol for those is to report those as negative because your body can't change that type of methamphetamine, the non-bioactive form. It can't demethylate it. And so if you see methamphetamine without an amphetamine, that normally means that they're using something other than a street drug or digoxin. Those are the two big things that I hear out of questions about amphetamine testing.
Can you, I'm sorry, what you just said, can you repeat that? So if
Sure.
you see a test that's positive for methamphetamine, are you saying
Methamphetamine.
meth, M-E-T-H?
Mhm.
So if you see a test that's positive for methamphetamine, but negative amphetamine, you're gonna report it to us as negative.
Correct.
And,
So the reason for this is because of,
You can't
it's a chemistry thing called stereoisomers. Methamphetamine has two stereoisomers, one that's biologically active. So humans, other animals respond to the bioactive form in a particular way. They produce the high that people who use illegal methamphetamine get. But for the non-bioactive form, your body can't change methamphetamine into amphetamine. And so the test itself, the initial test that we use to look for methamphetamine in samples, can respond to very high levels of this inactive methamphetamine. And so you could potentially have a screening positive, and you could see it in a confirmation test. But if you don't see a corresponding amphetamine to go with the methamphetamine, then there's the potential that you could be, if I reported to you a positive methamphetamine, if there's no amphetamine present, you could go to a patient and accuse them of using methamphetamine, and they would not have been.
and so what are the cold medicines that you're seeing could report a positive?
The only one that I am aware of is a Vicks inhaler. Vicks inhaler is the thing that we know contains L-methamphetamine, or the inactive methamphetamine.
And that would give you what kind of result?
That would give you a positive methamphetamine with no amphetamine present.
Okay. Oh, okay.
Now, it's important that if this is a thing that becomes something where you have to talk to a patient about it, that you don't go, oh, are you taking a Vicks inhaler? Because of course, that'll be the thing that they latch onto.
Of course. The other thing, when you see results, because I've seen this on a couple of patients when I'm screening, where the test will come back and it says urine was very diluted. So when that happens, and I don't know if it's what the patients are doing in the bathroom, when we're asking them for their urine, if they're putting, well, I don't know what they're doing, actually.
Right.
But if we see, when we see that, that's you telling us what exactly? Besides that, is that, like, are you telling us that it could be that the reason why the drug that we're looking for is not showing up could be, like, could diluting a urine sample, if they're taking a medication like they're supposed to, still show up?
Well, let me get into that. I have a section for that in my list.
Oh,
So,
okay.
I do have a question about the amphetamines.
mhm.
If somebody missed a couple of days of them, is it reasonable that their urine would be negative?
So there are two questions there. One of them is, are you always going to see an amphetamine positive for a patient who's taking Adderall or Vyvanse or another amphetamine-containing medication? And the answer is not always, because the test that we're using to look for it is one that's designed to look for abuse. So there can be cases where you would have a patient who's taking their prescription where you might have a false negative. If that's the case, you can call the laboratory and say, please perform a confirmation test and make sure that we actually caught the drug. That this patient is actually taking their medication, we just didn't see it because of the cutoff on the screening test. Cutoff is where we determine whether or not a sample is positive or negative. So on an amphetamine test where the screening test cutoff is 1,000 nanograms per mil, if the instrument response is 999, we'd call it negative. If the response is 1,000 or greater than that, we would call it positive. A negative result doesn't always mean there's no drug present. And so there are cases like this where you might want to call the laboratory and say, hey, we have this particular situation, can you take a closer look at this and make sure whether or not there is actually drug present?
Okay.
And then the other one is the amount of time it takes for a drug to become undetectable. So we should have another chart going around. John, do you have a detection time chart? Or did you only have metabolism and,
I have this one,
okay,
this one.
okay.
But this is approximate window of detection on.
Right, that's the detection time chart that I was
Yeah.
looking at.
Yeah, so going back to what Sean asked you, if the patient says to me, yeah, you know, Dr. McIntosh, I haven't taken it in 3 days. And
For
then,
amphetamines, 3
Right.
days is certainly enough time for it to be undetectable.
it is.
It's very specific to analyte, so like opiates, depending on the person, most people you're able to detect opiates in their urine for up to 2 days after use. There are some people who are fast metabolizers, who you can't see after about 24 hours from use. There are some people who are slow metabolizers, who you can see for up to 3 days following use. The slow and fast metabolizers are small segments of the population, and so you shouldn't expect that as a standard thing. I would be much more worried prescribing for a fast or slow metabolizer that you might cause the person to overdose, especially with slow metabolizers.
So there's this screen, there's 2 tests that we have been sending over to you all. First, we would just, there's the urine tox 9,
Mhm.
like basic. And then there's the expanded urine tox profile.
Okay?
If we're trying to capture to see if the drug is actually in there, and we send the expanded urine tox to you all, does it automatically, when the test comes back, and I don't know, are they automatically doing that screening? Like you know when you said we would call if there's something in question and you would do a confirmation test?
Mhm.
Do you automatically do the confirmation with the expanded urine? It's called expanded urine tox with confirmation, that test.
Okay, so the 2 panels that you're talking about, the urine tox 9 and the expanded tox profile,
With
both
confirmation.
behave the same way. They both, if the screening test, the initial test is positive, we send that sample on for confirmation. The difference is that there are different components between the 2 tests. Particularly the expanded tox profile also has the specimen validity that tells you whether or not a specimen is dilute. That's the biggest difference between the 2. There are some differences in reporting as well. I actually think that the urine tox 9 is an old panel. It's probably on the order of 10 or 15 years old. And the expanded tox profile is more updated.
So we should be using that one.
I would say that my opinion is that it gives you better clinical use.
To
Then-
do the expanded one.
Right. And it's not a difference in reimbursement. So insurance payers don't charge differently if you order a urine tox 9 versus the expanded.
Okay.
All right, so the next place where we have some discrepancies in what you might expect to see, sorry, John.
I want to go back to that, what Mike just said about the payment. If you have any patients that are self-pay, there is a difference in if there's insurance, reimbursement through insurance, and then there's self-pay. So the more you order, the larger the bill for self-pay patients. Or the high deductible plans, a lot of people switching over to high deductible plans that may incur more costs up front before they meet their deductible. So, and going around on this here, there is a, if you notice at the top, there's a urine drug reference chart, and then there's an oral fluid on both sides of these. So if you look at the header, that's why you might see some differences. A lot of people look at the chart and wonder why, but there is that's the difference. One's a urine drug and one is a oral fluid testing. Thank you, sorry about that.
All right, so the thing I was going to move on to are benzodiazepines. In benzodiazepines, there are some things that many people expect to see. One of them is clonazepam. Patients who are on Klonopin will not have a positive response to the benzodiazepine screen.
Oh, say that again?
So
Patients
if your
on Klonopin?
patient taking Klonopin will not have a positive on the benzodiazepine screen.
So there's a test for that?
There's a specific test for clonazepam. And this is just one of those things where the initial test, the test that we use to do the majority of the determining whether or not a sample is positive or negative, simply does not respond to that drug. It's built so that it responds to the majority of benzodiazepines. It just doesn't respond to that one. There is a specific test for that. The other thing that I'd like you to be aware of is if you have patients who are taking lorazepam, Ativan, that patients on low doses or who have had intermittent doses or are a day or so past their dose, that you may have patients who have a false negative. So while the benzodiazepine screen cross-reacts with lorazepam, there are some patients who end up with false negatives. So if you have a patient who's taking Ativan and they had a negative screen, that's another place where you can call us and say, I need to add on a confirmation for benzodiazepines for this particular patient.
How long do you hold on to the urine for?
We hold on to all samples for 10 days following testing
Okay.
with the idea that,
Urine?
sorry?
We're just talking about urine there.
Well, yeah, and actually the oral fluid specimens that we get, we hold on to those for, I want to say, 3 weeks. And so if you have samples that have come to the lab for testing and you need to have some additional testing done, you should still have it as long as you know it's not a week and a half beyond. I need to, I'm looking at my list in my head. The next most common question I get is about opiates. So the opiates test, if you actually get a chance to look at the components of an opiate test, you'll find that it is codeine, morphine, hydrocodone, hydromorphone, oxycodone, and oxymorphone. If you have patients who are taking tramadol or fentanyl or a variety of other opioid-type compounds, those compounds do not respond to the screening test, and they require a specific test.
What are the other ones? You said fentanyl and tramadol, but then you said a variety. What do you mean? Like,
There are a number of compounds that are prescribed, so things like carisoprodol and tapentadol and gabapentin, dextromethorphan, just a variety of things that people have used or abused that are not detected by one of the existing panels. So if you're looking for something, if you're looking for a result for a particular drug, and you look at the chart that tells you what's going to show up in a particular test, if you're not seeing the compound that you expect to see, then you're going to have to contact us for a specific test for it. I'm sorry, I'm seeing a question.
No,
Okay.
I'm going to wait till after you finish that.
Do we contact you, or do you just write it on a piece of paper and say you do that test, and then you call us if you can't do it?
It depends on if you're ordering it up front. If you know that the drug screen doesn't look for fentanyl and you need it,
Yeah.
then you can submit the sample with a request for fentanyl and we'll just do it.
Like, what would you do if there was a, the panel with the confirmation is ordered and the provider handwrites something that's included in the initial test panel?
So,
There's a duplication, if you will.
so where we see this happen is somebody orders a panel that includes, say we have a panel that includes opiates, and you also write in opiates and confirm all positives on the requisition, then we're going to order the test that has the opiates with confirmation as part of it anyway. It's already part of your panel, it's redundant, it's not something we're adding something special on. We're just going to go ahead and do the panel as ordered. if you were to, it's not possible from the panels that you've discussed, but we do have some places where we've got panels that have no confirmation and panels where the screen reflexes to a confirmation. If you order a test, 2 tests for the same substance, you're looking for cannabinoids, and you order a test that's screen only and one that's screen with reflex to confirmation, we'll perform the one that has the reflex to confirmation. And you order the same test with 2 different cutoff levels, we'll test the one with the lower cutoff level. So there are ways in which our lab system, our lab information system helps us deal with those. And we're trying to do it so that we're doing the most specific marked test.
How about methylphenidate?
Methylphenidate requires a special test. And so if you're expecting to see it in amphetamines, you will not.
So even the expanded test doesn't test for methylphenidate?
That's correct. Now, some of these things we are on our way to building more extended panels for, but they're not things that are present in our panels right now. I actually am finishing a validation for things like fentanyl and tramadol, so that there are screening assays available for them that we can then build into a panel. Part of the problem that you run into is there are 2 concerns. One of them is a billing concern. So if you have patients who are on Medicaid, then you're required to order only tests that are relevant to that patient's condition. And if you order a panel that has 18 components on it, somebody at Medicaid is going to look at it and say, this is really not appropriate for this particular patient. And then they're going to beat you and I up together because they always get a provider and a lab together. The other concern with it is that you have the potential that the more stuff you add to a test, the more likely you are to increase the amount of time it takes for the lab to get all of the testing done and back to you. I do like the idea of saying we have a particular thing, like you have a patient who is prescribed an opiate of some sort, rather than trying to identify which one it is and then order the appropriate test, that you order something that has all of the likely opiate components. The other thing that you will find about this is that people come up with new stuff. New stuff is a big topic of discussion among toxicologists because people invent things faster than we can actually test for them. So if it's very common, so 5 or 6 years ago, it was really common to see meperidine as one of the non-standard opiates that people tested for. But with meperidine prescription use down significantly because of its health concerns, you don't see that as frequently anymore. So if we built a panel that had meperidine present in it, we'd be doing a bunch of testing that was relatively useful. Same thing for propoxyphene. Every time somebody puts something on or takes something off of the market, that affects the sort of the quality of testing that you get. I'm sorry, John, you had a...
I was at Walmart, I'm a driveway mechanic, and I took WD-40 and a couple other things up to the register. She says, I need your ID. Why do you need my ID? WD-40. Yeah, that's the new one now.
Oh,
I said,
really?
what is that?
Puffing. Yeah.
They're huffing and puffing on it. And
Oh.
being here, being with Mike, you know, I get a lot. I'm a beginner still after years of listening to Mike, but that
I got
hit
some
me
serious
over the
cash
head
in my
like a club.
garage, huh?
I put WD-40, so that's what, I was gonna say something, the chasing of what's on the streets right now is just incredible, how fast, and just, so, I'm sorry.
Oh, no, you're okay. I had 2 questions. The first one was about that expanded urine tox profile. That it gets reflexed to confirmation if there's a positive, correct?
That's correct.
But if there's a negative, where we're questioning why it's negative, we could call you to reflex it.
That's
Or
correct.
we have to call you to reflex it.
You have to call it to order confirmation
Right.
specifically.
It only goes confirmation if it's a positive.
That's correct.
Okay, that was the first question. And the second one was the breakdown with the opiates. The hydromorphone is dilaudid, right?
Mhm.
And if I have a patient who's on Vicodin,
Mhm.
which is what, the Tylenol
It's-
and hydrocodone,
Mhm.
when I do a urine tox on them, why am I seeing hydromorphone in there?
Well, that's one of my next questions, so let's move right into opiate metabolism. There's actually a handout that John has to pass around for opiate and benzodiazepine metabolism. So in opiates, what you should expect to see is codeine metabolizes into morphine, hydrocodone metabolizes into hydromorphone, and oxycodone metabolizes into oxymorphone for the vast majority of patients. There are some other metabolic products that happen as well, but these are the primary ones. They're the ones that we measure for. So if a patient who's taking codeine, they're actually going to have a positive for both codeine and morphine. If a patient who's taking Vicodin, they're going to have a positive hydrocodone, but they're also going to have a positive hydromorphone in most cases.
In most cases.
Same thing for oxycodone. A patient on OxyContin or another form of oxycodone will have a positive oxymorphone that accompanies that. The other thing that you see that is a smaller metabolism pathway is for both codeine and morphine, there's a minor metabolic pathway that leads to either hydrocodone or hydromorphone. So patients with high levels of codeine present in their system will also have a morphine because you're metabolizing codeine into morphine, but they may also have a small percentage of hydrocodone present in their sample. The lower the cutoff is, the lower the level at which we report to you a positive, the more likely you are to see a positive hydrocodone for a patient who's taking codeine. So if you see a result that comes back to you, especially from that expanded tox profile where you're getting a numeric result back, you see a very high level codeine or a very high level morphine and a corresponding hydrocodone or hydromorphone that's small, say between 50 and 300 or 400, you can be pretty sure that that corresponding hydrocodone hydromorphone result is just a metabolic byproduct. It's not your patient is taking both codeine and Vicodin
Oh, I see.
or morphine and Dilaudid.
You're right. Now, do you recommend that when we're screening and we're testing these patients and that our collection cups should have a temperature screen on it?
Absolutely.
Absolutely. So,
The cups that we provide, or that you order through ACM, if you're getting those translucent snap cap cups,
yeah, we do.
those have built-in temperature strips.
No, well, not all, do all of them have that?
Yeah, all the
Yeah.
snap cap
Specific
ones.
ones.
We have specific ones, but we also have the ones that snap that don't have the temperature on it.
Well, those
You
were
might
the,
have
those
a
were the screw on.
Sterile cups, those are the
The sterile cups with screw-on lids do not.
But you're saying that for this urine tox, we should be taking the temperature.
Absolutely.
So if the temperature should be the body temperature.
Temperature should be between 90 and 100 degrees
Okay.
within 4 minutes of collection.
90 to, say that again, I'm sorry.
90 to
90 to
100.
100
Within 4
4
minutes.
minutes.
And if it's not,
If it's not, my recommendation is that you ask that patient to recollect the specimen. Do it immediately.
immediately tell them they gotta give it.
Yeah, they have to come back in, they have to do it immediately. There are some patients who are not going to comply with that sort of thing, and that's a behavioral clue for how you treat that patient.
When you say immediately, like, for example, if we just collect it, they're still sitting in the room, come back and I look and I say, oh, this is quite cold. Go back and tell them I need another sample
Yes, before they leave the clinic.
before they leave the clinic.
Yes.
I can't go.
So,
Yeah.
Here's some water.
Because that just
Here's the
happens.
sink, here's the cup.
all right, so let me finish out my opiate metabolism thing so I don't get that too lost. But, so you have this ability to metabolize codeine into morphine, hydrocodone into hydromorphone, oxycodone to oxymorphone. There are not metabolic pathways that lead backwards. So if you have a patient who is taking morphine, they have a prescription morphine, and they also have a codeine result, then there's something else going on. If you have a patient who's taking Dilaudid, but they also have a hydrocodone response, then there's no biological way to get that. Same thing if you have a patient who's taking Opana who should have an oxymorphone positive. If they have an oxycodone positive as well, then that's an indication they're doing something other than taking just their Opana.
Wait, okay, yeah, so now I feel like I'm in chemistry, and, you know.
So
You're
in all
saying
of
that
those
it can't go
cases,
back with the metabolite equation,
Right.
but, so this little thing you hear with the
So
arrows,
if they're on morphine,
yeah,
you can't go this way, they're not gonna be positive for codeine.
right,
So you
okay.
have codeine.
So it has to go with the arrows.
right.
It's not gonna go the other way.
But if they are taking hydromorphone, which is Dilaudid,
Mhm.
and we did a screen, it can only break down to hydromorphone. That's
Right.
it. It shouldn't show anything else.
Right, you shouldn't see hydrocodone with that.
It won't go back.
It won't go back.
It
Okay.
doesn't. It does not go back. There's no, so I
That's
talked
all
to,
they're taking.
Right, okay. Oh.
so a patient that is prescribed Dilaudid who has a morphine positive, there's no metabolic pathway to go from hydromorphone to morphine. There's no pathway to go from hydromorphone to hydrocodone.
So they're busted.
So patients with results that don't match your metabolism table, that's always a red flag
Red
that
flag.
something is going on.
Okay.
The other big metabolism question that I have is in benzodiazepines. I talked about clonazepam already, so you should be ordering a clonazepam specific test for patients who are on Klonopin. If you're looking at patients who take Valium, Valium is diazepam. Diazepam metabolizes into nordiazepam, and then nordiazepam metabolizes into temazepam and oxazepam.
Nice.
Oxazepam is Serax, and temazepam is Restorel. And so there's a potential that if you're looking at a result and you see nordiazepam, oxazepam, and temazepam, that patient is most likely taking Valium, because there isn't a metabolic pathway from temazepam or oxazepam to nordiazepam. But there's still a potential that if you don't see all three, you could still have a patient who's on one of those three medications. When you have that look on your face that I just saw right over here, and you're like, what in the world do I do with this result? That's when you call me and you say, what in the world should I do with this particular result? Does this mean my patient is actually taking their Valium, or are they taking Restoril? There aren't a lot of people who prescribe Serax. Is there any Serax prescription out of your clinic? It's really uncommon. So patients who are taking Valium, for example, should not return a response that's positive for lorazepam, which is Ativan, or for alpha-hydroxyalprazolam, which is a metabolite from Xanax. So if you have a patient who's prescribed Xanax and they're showing anything other than alpha-hydroxyalprazolam, that's a sign they're taking something other than their prescription. Now, the metabolism chart will help you out as you're looking at this, but when you inevitably run into a weirdo case and you need somebody to look at it and say, what is my patient actually doing, please give us a call.
Yep.
John's got a sheet of numbers for
The
people
most
to
important
call.
thing you'll get today.
How do you
800 number
contact us to
hotline.
make sure that
I
you're,
get-
What does
Oh,
a poppy
we're
seed
gonna
say
tell
here?
you what's going
I was
on.
gonna-
Right there, yeah.
What's
this number, once I get the majority of attention
And
done.
it cascades to an open line, and there's somebody that has to pick that line up, pull up the patient, pull up the result, and you'll be able to talk to someone that knows.
That knows the
Well,
answer.
they can guide you, they don't interpret the results, but they know how to read the results to you and answer your questions.
Okay.
All right, so,
I'm gonna leave these right down here on the table, because this is the lifeblood.
so I get a question about what happens with patients who use poppy seed or consume poppy seed products, poppy seed bagel, streusel, cake, muffins, whatever. There are cases where patients who are eating poppy seed products can end up with opiate positives. The only thing that they can be positive for is codeine or morphine. So if you see a patient who has a positive hydrocodone and hydromorphone and they say, oh, I ate a poppy seed bagel, that is not a reasonable explanation for the result.
So only codeine and.
Only for codeine and morphine.
Shows up for poppy seed.
There were a series of studies
Does
that
it
were
go
done.
to hydromorphone?
It does not. The only thing that you see from poppy seed usage or poppy seed consumption is codeine and morphine. That's it.
And how much poppy seeds are we talking about here?
Yeah.
It really does not
I mean,
have to
one
be that
bagel?
many. Yeah,
Oh, wow.
And you could test positive.
yes. You see it only in,
Is it raw?
you only see it in certain types, like
Oh.
there are bakeries that use unwashed poppy seeds, you're more likely to see this positive response from. But it can show up from a single product consumption. It doesn't have to be a lot of poppy seeds that the person is eating. It's very, very difficult to figure out when the result is low. What we expect to see is that morphine should be greater than codeine, and that the codeine result, if it's present, should be somewhere between 5 and 50% of the morphine result. So if the morphine result is 500 and you have a codeine result of 50 or 75, that kind of matches the profile, but there's still no way to say for sure from the lab perspective that it's definitely due to poppy seed consumption.
Well, I know what I'm gonna eat after my workouts now.
All unwashed poppy seeds?
Let's find out where they're
calling
sold.
around.
I know, I'm going around.
Test
What's
them.
the minimum amount of urine that you guys need to run these tests and get accurate results?
It depends a bit upon the sample. I would say that if you're collecting sample, that you should send us at least 30 mils.
At least?
At least 30 mils. So let me give you a scenario. You have a patient who's taking opiates and they're taking something else. You get a sample that comes to the lab. When we get an opiate positive, we're going to pour 2 mils of sample out to do the confirmation test following the screen. We normally pour 2 mils of sample for the screen itself, another 2 for the confirmation. If we have to reperform that confirmation for some reason, like we analyze these samples in batches, and if the batch of samples is not acceptable, we have to send all of them back for another test to make sure we're going to report to you a valid result. If we have to do that once or twice, then we're talking about, say, 2 to 4 mils worth of urine that's for opiate testing. I had a patient that I was looking at the other day that had a positive for opiates, cocaine, ETG, or the alcohol metabolite, and what else?
Marijuana, gotta be.
Yeah, there probably was a marijuana. So the more positives there are on a sample, the more likely it is that we're going to exhaust the amount of urine that we have. So There are places where they collect small volumes, that they collect 10 or 15 mils, and the sample is negative, that's no problem. But if it's positive, it's going to get to the point where somebody has to call you and say, I have a little bit more than a mil, and I can do one of these 3 confirmation tests, which is the most important. And that's the thing that we're trying to avoid is, if you're collecting relatively large volumes, if you're collecting 30 mils or more, your temperatures are more likely to be accurate during collection. Somebody is less likely to be able to pass off a low volume cold sample to you than a high volume cold sample.
So when they say they can't pee for us and they only give us a drop, that's like dice.
Yeah. So in collection practice, what I see in a lot of places is patients are required to give a sample either on a scheduled or an unscheduled visit. Unscheduled visits are great for catching people doing things that they are not supposed to do. When you collect, you should be testing, you should be looking for a reasonable level of urine. Most people are producing somewhere, depending on bladder capacity, somewhere between 50 and 400 mils of urine in a void. Thinking back to A League of Their Own, anybody? Tom Hanks. So you can have, I expect that most patients are able to produce that level of urine. For patients that are not, so patients who are on dialysis or patients that have conditions where they may have low void volumes, that there is the potential that we can test oral fluid for drugs of abuse. They're not, oral fluid and urine are not truly comparable to each other. If you're testing oral fluid followed by urine on different visits for the same patient, you may see results that look discrepant, but it is better than having no potential to test a person. So I had a question about what sorts of prescription drugs give false positives. Wellbutrin, bupropion, is the thing that causes more false positives for us right now than anything else. It's more likely to cause them. We see it anecdotally reported for patients who are prescribed bupropion having positives for amphetamines or MDMA or buprenorphine, Suboxone. So there's potential that you can see false positives for patients who are taking Wellbutrin. In all of those cases, if we had a false positive on the screen, the confirmation test will then be negative. So screening tests, the initial tests are prone to false positives, but confirmation tests are not. If you have a screen positive for opiates and a confirmation positive, then you can be sure that that substance is present. If you have a screen positive and the confirmation is negative, that's your indication that that patient didn't use that drug or that drug class. The one that we used to see more than anything was trazodone, had positives for MDMA, and it's still possible that a patient that has that is taking trazodone could potentially have a false positive for ecstasy or MDMA in their screening test, but the confirmation test will show that it's negative. Talked about metabolism, we went through a lot of that. Do long and short acting formulations affect screening? Really no, except for the ability to detect things. So a patient who takes OxyContin may have longer acting, may have their effect for a longer period of time, and the ability to detect the drug may be extended slightly. But normally we're not talking about adding a day or 2 days on. If a patient only has an additional 6 hours of action from taking a long-acting drug, then you're only going to see that time extended by about 6 hours. Those types of extended action formulations are meant to prohibit or to inhibit the absorption of the drug into the body. They don't do anything to affect the amount of time it takes to excrete those drugs back out again. And then over-the-counter drugs that might cause interactions are going to be things like there are a variety of things like Sudafed causes positives for amphetamines. That's the most common over-the-counter drug that you see that interacts with a screening test. But once again, on confirmation, a patient who took Sudafed and had an AMP positive screen will have negative confirmation. The majority of these things are taken care of just by confirmation testing.